Hello everyone, welcome to Unacademy. Let's crack NEET PG. I'm Dr. Shilpa Dinesh. I'm a practicing pediatric consultant and an educator in Unacademy. I have an experience of teaching undergraduate and postgraduate medical students, and I have done my MBBS and MD from Rajiv Gandhi University of Health Sciences. Today we'll be having a continuation of yesterday's topic. So yesterday we have started the discussion on aplastic anemias, right? So the inherited causes of aplastic or pancytopenia. They will be discussing two other syndromes which come under the inherited causes of aplastic anemia. So we'll be discussing Schwartzman-Diamond syndrome and we'll be discussing this keratosis congenita. Okay, so these two topics along with Fanconi anemia will be very important for your inherited causes of aplastic anemia. Okay, so these both these conditions have a typical presentation. So if a clinical scenario comes, you should be able to diagnose both these conditions. Okay, so before that, I would want to talk a little bit about Unacademy. Unacademy is India's largest online learning platform. There are a lot of benefits you can avail from this platform. Firstly, the daily live classes. There are various educators in this platform who have regular classes happening here. Okay, so you can attend your favorite educator's class, engage in discussion, ask your doubts, and all these doubts will be immediately cleared in the live chat box. Also, the structured course. So whenever you're preparing for your entrance exam, you need to have a structured approach. You need to plan really well. So by the time you give your entrance exam, you would have revised very well. Okay, so here in Unacademy, all our courses are structured in line with the exam syllabus and it will be a huge boost for your preparation. Next, coming to the live tests and quizzes. So again, whenever you're preparing for your entrance exam, you need to evaluate yourself. You need to know what are your strong areas, what are your weak areas. So that will help you to concentrate on the topics which are, once again, concentrate on the topics which you are not so strong at. So that is possible only if you attend as many tests and quizzes as possible. Okay, so here in Unacademy there are regular live tests and quizzes happening, and attending these tests will help you to evaluate and analyze your performance better. Okay, next, coming to the unlimited access. So once you subscribe to the subscription, you get unlimited access to all the classes that is exclusive to the subscription platform. Okay, so once you subscribe, all the classes you get access to, and even if you have missed the live class, you can go back and watch the recorded classes again and again. All this in the comfort of your home, in the comfort of your own devices. So I would highly recommend this platform, and using this platform in the beginning part of your preparation will take you a long way. So these are the top educators in this platform and they have regular classes. You can go and attend their classes as well. Okay, so there are various courses in this platform which have been offered. So there are batch courses, there are foundation courses, there are crash courses. So you can go check the Unacademy app, the Learners app, and there will be various courses listed. So you can go and check that as well. And all the 19 subjects required for NEET PG preparation are taught in this platform. Next, so this is the NEET PG subscription package. So as you can see, the NEET PG subscription package varies from 1 month to 2 years. Okay, so the 1 month subscription package, 1 month to 2 years. So I would recommend the 1 year or the 2 year subscription. Okay, so for the students who are giving their NEET PG 2021, for them the 6-month subscription would suffice. So why am I saying is this 1 year or the 2 year compared to the 1 month or 3 month, it becomes more reasonable. Okay, when the price with the price. So that's why I suggest the 1 year or the 2 years. So you have a lot of special classes, you have this YouTube, you can attend these free classes and then check on what you want to subscribe to. Okay, so the 1 year subscription costs you 25,000, and especially for the students who are in their 3rd year, final year, in their internship, for them the 1 year or the 2 year subscription becomes very reasonable. Okay, so the 1 year subscription is 25,000, and using my code Shilpa 10 you get a 10% discount and it will come up to 22,500. The 2 year subscription is 30,000, and using my code Shilpa 10 you get a 10% discount and it will come up to 27,000. And for the students who are giving their NEET PG 2021, for them the 6-month subscription should be good enough. Okay, so that is 20,000. Using my code Shilpa 10, you get 80. It comes up to 18,000. So based on your requirement, you can take whichever package you want. Okay, so but the prices are very reasonable, so I highly recommend it. Use it in from the beginning of your preparation. Okay, so now we'll go to today's topic. The first topic for today is the Schwartzman diamond syndrome. Okay, so this is one of the inheritable cause of pancytopenia or aplastic anemia. Okay, so this is one of the inheritable causes. Okay, so over here, what is the presentation? So these children will have aplastic anemia. So there will be a presentation with anemia, thrombocytopenia, and very important is these children will have pancreatic insufficiency. Pancreatic insufficiency. Okay, that you should know. So aplastic anemia with pancreatic insufficiency, you have to keep in mind Schwartzman diamond syndrome. Okay, next. So what is the inheritance of this disease? The inheritance is autosomal recessive. Okay, so the inheritance is autosomal recessive. Next, uh, uh, next coming to the gene which is affected. So what is the gene which is affected? Okay, so gene which is affected is the SBDS. Okay, so remember SBDS. So Schwartzman diamond syndrome. So just remember the B part. SBDS gene. Okay, so this is located in the chromosome 7q11. Okay, so the main thing about this is this gene is important in the ribosomal uh, genesis. Okay, ribosomal biogenesis. Okay, so so that is why now this is a mutated gene. So once it is a mutated gene, this ribosomal biogenesis doesn't happen properly. Okay, so ribosomal biogenesis happens because of this gene, but since the gene is mutated in this disorder, that doesn't happen. Okay, so how do these, what are the what are the abnormalities, what is the pathology in this disorder? So one I've told is the pancreatic insufficiency. So what is how does pancreatic insufficiency happen? So pancreatic insufficiency happens because of the failure to develop the pancreatic SNR development. So failure of pancreatic SNR development. Okay, so that is why pancreatic insufficiency happens. Now in these children there is even the bone marrow failure. Okay, so bone marrow failure, this leads to anemia, thrombocytopenia and leukopenia. Another very important thing you should know is the neutrophils. So there is this neutrophil abnormality, so the motility, the addition of these neutrophils are also affected, and as a result these patients will have neutropenia. Okay, so these are the features you need to know. So aplastic anemia, having pancreatic insufficiency, okay, and having neutropenia, you have to keep in mind Schwartzman diamond syndrome. Okay, so now I've told you in the clinical already told you that there is pancreatic insufficiency. So what happens? So when there is pancreatic insufficiency, what happens? How do these children present? Okay, so they have fat malabsorption since the time of birth. Okay, because of pancreatic insufficiency, there is fat malabsorption. Okay, from the time of birth itself. But though there is fat malabsorption, not necessary there has to be steatorrhea. Okay, there is fat malabsorption. Okay, so next what happens? So now I've told you these children have severe anemia, thrombocytopenia. So they can have, if the thrombocytopenia is very severe, they can have a bleeding manifestation. They can have features of anemia. So that is one thing. Next is the infections. So now these children do not have neutrophilia. So they have, do not have neutrophils. So there is neutropenia. So these children have a high chance of developing bacterial infections. Okay, bacterial and fungal infections. fungal infection. So this happens because there is neutropenia, there is a neutrophil dysfunction, and also there is immune deficiency. Okay? So this is the reason these children have recurrent bacterial and fungal infection. So next very important thing. So next very important feature is short stature. So already in Fanconi anemia, I have told there is short stature. So even here there is short stature. Okay, Schwartzman-Diamond syndrome also has short stature. So here what happens is the growth velocity of the child is normal. So what is growth velocity? So I have told you in my class on short stature. So basically, now just imagine this is the third centile, okay, and this is the 97th centile. Okay, so now the child is, if the child is growing in the same velocity, it's not going up and down like this. So if the child is growing in the same velocity which it has to go, it is a normal growth velocity. Okay, so the child is growing in the normal velocity which it has to grow. But when you check the height, these children will have a height less than the third centile. Okay, so the height is less than the third centile. So that is why they have short stature. Okay, the height is less than third centile. Also, when these children grow to an adult height, that time also their height will be less than the 25th centile. Remember this. Okay, so very important: pancreatic insufficiency, bacterial and fungal infections, next the short stature. Finally, coming to the skeletal abnormalities. So skeletal abnormalities, not necessary they have to have this. So there is a varying presentation. Okay, some children will have delayed bone maturation. There is delayed bone maturation. Fine. There is delayed bone maturation. There is thoracic dysplasia, I mean dystrophy. So basically there is wasting of the thoracic muscles and all that. Thoracic wasting of the bone. The bone is also thin. Okay. Thoracic dystrophy. Okay. And the ribs in these children are short and flared ribs. Okay. Short and flared. And in some patients you can see there is liver involvement, so there will be hepatitis. Okay, this is very rare, so you don't have to keep in mind, I'm just telling it over here. There will be hepatitis and increased liver enzymes. There could be dental abnormalities also. So this, no, not a big thing to remember. So main thing you have to remember in Schwartzman-Diamond syndrome is pancreatic insufficiency, short stature, and bacterial and fungal infection. That is because of neutropenia and because there is neutrophil dysfunction. So that you have to keep in. Okay. So next, coming to the laboratory findings. So first thing, so when you get a CBC, what do you see? So you see there is anemia, there is thrombocytopenia, okay, there could be leukopenia, okay, so this leading to pancytopenia. Another important thing is these patients will have neutropenia, and this neutropenia, not necessary it has to be throughout. So whenever you get a blood test in a child with Schwartzman-Diamond syndrome, not necessary every time you get. So there are two types of presentation. So some children have a chronic persistent presentation of neutropenia, some children will have intermittent. So sometimes there will be neutropenia, sometimes there won't be neutropenia. So that you should know. Okay, there will be a chronic persistent presentation, okay, or it can be intermittent. Okay, so now coming to the pancreas. So in the pancreas, so when you get a CT abdomen or if you get an ultrasound, so what do you see? You see that there is fat replacement of the pancreas. Okay, pancreatic tissue. So there is fatty replacement of pancreatic tissue when you get a CT or a ultrasound. Okay, so that is very important. So fatty replacement. So when you get the pancreatic enzymes are also impaired. So the trypsinogen and amylase is also decreased. So you should know. And some patients will have decreased immunoglobulins. So IgG will be decreased. Okay, and also when you get a peripheral blood, you will see there is decreased, absent B lymphocytes. So tell me one other immunodeficiency disorder which, when you get a peripheral smear, will show absence of B lymphocytes. What is that? Do you all know? So Bruton's A gamma globulinemia is one of the disease where when you get a peripheral smear, you see complete absence of B lymphocytes. Over here, it is decreased to absence. So it could be generally reduced B lymphocytes. Okay. Next, coming to the complications. So what are the complications? So these children who are affected with the Schwartzman-Diamond syndrome, they have a high chance of going into myelodysplastic syndrome or leukemia. Okay, so there's a chance of 8 to 33% of going into, you just take 8 to 30%. So 8 to 30% chances of going into leukemia or myelodysplastic syndrome. That you should know. Tell me which tumors did in Fanconi anemia? What was the higher chance of which cancer would they uh, going to having an increased risk of which cancer in Fanconi anemia? So in Fanconi anemia, there were solid tumors like the squamous cell carcinoma of the head, neck. Okay, so that was more common there. So here it is more common to have myelodysplastic syndrome or the leukemia. Fine. Next coming to the treatment and prognosis. So first thing is, one second. Yes, very good, Ganesh. So that is right. The squamous cell tumor. So now coming to the treatment. Okay. So in the treatment, first now what will you do? There is fat malabsorption. Yeah, both very good, Aparna, very good, Ganesh. Both of you all are right. So in the treatment, there is fat malabsorption. There is fat malabsorption, right? So first thing is you have to see that there is pancreatic enzyme replacement. What we do in these pancreatic enzyme replacement. Okay. And next is you give fat soluble vitamins. You give fat soluble vitamins. Okay. Next, for there is neutropenia, right? So what do you give for neutropenia? What is the drug which we give? I have talked about this. Tell me, what is the drug which we give in children who have neutropenia? So in neutropenia, we give granulocyte colony stimulating factor. Okay, filgrastim. Okay, filgrastim we give. So this is given. So this will help in reducing the, improving the neutrophil count. But the problem with this is giving the granulocyte colony stimulating factor, it can worsen or it can increase the risk of going into leukemia. Okay, so it can increase the risk of going into leukemia. Okay, so in these children you have to get you have to evaluate regularly for early detection of leukemia in these children. The best cure is what? The cure is hematopoietic stem cell transplant. So this is the cure for Schwartzman-Diamond syndrome. You should remember this much. So we have discussed, there is nothing more than this to be known. Okay. So I've told you, so the inheritance of Schwartzman-Diamond syndrome is autosomal recessive. Okay, the gene which is affected is the SBDS gene in the 7q11 chromosome. This SBDS gene is required for ribosomal biogenesis, which since it is mutated in this condition, that doesn't happen. Okay, so the presentation is these children will have pancreatic insufficiency. Okay, this happens because there is failure of the pancreatic SNR development. Okay, next there is bone marrow failure. Another very important thing is there is abnormality of the neutrophils. There is chemotaxis of the neutrophil is not happening, mobility is not happening, there is neutrophil dysfunction, and that is why there is neutropenia in Schwartzman-Diamond syndrome. Okay, coming to the clinical features, there is pancreatic insufficiency, therefore there is fat malabsorption since birth. Okay, there is fat malabsorption since birth. These children, since they have neutropenia or neutrophil dysfunction, immune deficiency, they have increased chance of bacterial and fungal infection. Another very important thing is short stature. So you should remember short stature. The height is less than third centile. Skeletal abnormalities is delayed bone maturation, thoracic dystrophy, and short and flared ribs. Okay, so lab diagnosis, I have told you, when you get a CBC, they will see pancytopenia. Okay, and another thing about neutropenia is it could be chronic persistent or it could be intermittent. Okay, when you do the evaluation of pancreas, what do you see? There is fatty replacement of the pancreatic tissue by CT or ultrasound, and the pancreatic enzymes are decreased. Trypsinogen and amylase is decreased. And coming to the immunological part, the IgG is decreased. There is decreased or to absent B lymphocyte in the blood. Okay, so these children going to myelodysplastic syndrome or leukemia is very high. Okay, the treatment includes pancreatic enzyme replacement, fat soluble vitamins. Okay, and for neutropenia we give GCC, CSF, that is granulocyte colony stimulating factor. But the only thing is, since it's a stimulating factor, okay, it's a growth factor, it can increase the risk of leukemia. So that is why we have to evaluate these children regularly for leukemia, like for every annually you have to do. But the cure for these children is hematopoietic stem cell transplant. Fine. So we have done Schwartzman-Diamond syndrome. Now coming to dyskeratosis congenita. Okay. So this dyskeratosis congenita is a multi-system. So inherited multi-system disorder. Okay. So this has mucocutaneous abnormalities. Okay, mucocutaneous abnormalities, bone marrow failure, and there is high chance of going into high increased risk of cancer and myelodysplastic syndrome. Okay, so this you should know. So there is a triad for dyskeratosis congenita. So there is a triad you should remember. Okay, so the triad for dyskeratosis congenita is mucocutaneous involvement. Okay, but first thing is the skin pigmentation. Skin pigmentation. Okay, so there is hyperpigmentation of the skin. Okay, there is hyperpigmentation of the skin. Next is nail involvement. So these children will have nail dystrophy. Nail dystrophy. Okay, so these children will have nail dystrophy. Finally, they'll have mucosal leukoplakia. Leukoplakia. So remember this. So this is a ectodermal triad. Okay, this is the ectodermal triad or the mucocutaneous triad. Ectodermal or the mucocutaneous triad. So this is a child presenting with aplasia, aplastic anemia with skin, nail and oral or the mucosal involvement, then you would go for dyskeratosis congenita. So remember dyskeratosis, so involving the ectoderm, so keratosis. Okay, so dyskeratosis congenita. So remember, first thing to appear is the skin and the nail involvement. So first there will be skin and nail involvement, eventually it will go for mucosal leukoplakia. So that is after 10 years of age, or in some children it might be earlier also. Okay, so now coming to the pathology. So what are the genes which are affected? So the genes which are required for the telomerase activity are affected here. Okay, so the genes which code for telomerase complex are affected. Okay. So now the inheritance in these children are all the three. There is X-linked recessive, there is autosomal dominant, there is autosomal recessive. So the inheritance is Okay? So the inheritance is X-linked recessive. There is X-linked recessive, autosomal dominant, and autosomal recessive. Okay, so I will only tell the gene which is affected here in the X-linked recessive, that is the DKC1 gene. Okay, DKC1 gene. Over here, I don't want you to confuse, because there is a lot of genes like the TINF2 gene, TERs is also affecting the telomerase activity, but this is very important. The DKC1 gene is very important. Okay, so the inheritance can be X-linked recessive, autosomal dominant, or the autosomal recessive. You should remember this. Okay. So clinical manifestation. So what should you know on the clinical manifestation? So in the clinical manifestation, first thing is the skin pigmentation. Skin pigment. So this skin pigmentation can affect the face, the chest, the arms. Okay. So this skin hyperpigmentation affects these upper part of the body. Okay. Skin pigmentation. Next is the nail dystrophy. Then there is mucosal leukoplakia. Okay, then there could be persistent tearing in these child. Okay, in the eyes there is persistent tears. Persistent tear. This is because the nasolacrimal duct might be blocked in these children. Okay, persistent ocular tearing. Okay, next, what are the other eye abnormalities in these children? What are the eye abnormalities? So these children can have conjunctivitis, blepharitis. Okay, also they can have optic atrophy. Can have optic atrophy, they can have strabismus, they can have cataracts, Next coming to the skeletal involvement. So what are the skeletal involvement in these? So skeletal, first thing is they can have osteoporosis. Okay, they can have osteoporosis. Okay, there could be mandibular hypoplasia. And there could be avascular necrosis. Okay, that is the skeletal. Next, coming to the genitourinary abnormalities. So the urinary abnormalities is similar to Fanconi anemia. So can you all tell me few conditions which were associated in Fanconi anemia, the genitourinary abnormalities, like the kidney involvement. So what were the kidney involvements in these children? Okay, so one was, I had told you there was horseshoe kidney. Okay, horseshoe kidney. Okay, so there could be horseshoe kidney. And next, coming to the genital, so there will be hypospadias, phimosis, undescended testes. So these could be there. Okay, so these features, the genitourinary abnormality is similar to Fanconi anemia, but rest there is no features similar at all. Then you should be able to know. So all the three. At the end of this class, I will ask you questions on all the three. So you all should be telling me the answers. Okay, fine. So so you should be knowing about this. So one more thing is, the children can have hepatomegaly fibrosis, and some children can have pulmonary fibrosis as well. So but that is not very important. Remember another very important thing. So this is dyskeratosis congenita. So another thing is there will be fibrosis of the organs. Okay, fine. So now this is a picture. The first picture shows leukoplakia. Okay, there's a better picture in the next slide I've shown. I'll show you next picture. Mucosal leukoplakia. You can see over here the white plaques in the tongue. Huh? Leukoplakia. So can you see the dystrophy of the nails? The nail dystrophy is also there. nail dystrophy. So main thing, ectodermal features with aplastic anemia, it is dyskeratosis congenita. Okay, do not confuse. Nail dystrophy. This is the hyperpigmentation. So you can see some lacy pattern. So there is a lacy pattern of pigmentation which is seen in these children. A lacy pattern. Lacy. Okay, so that is seen. Okay, this is another picture where you can see properly the mucosal or the leukoplakia over the tongue. See, you can see there is dystrophy also of the nails. You can see there is some kind of a hardening, and the nail, nail where it is cut, you don't see a regular. There is some kind of irregular edge, and you can see there are vertical lines in the nail. Okay, so this might be the initial start for the nail dystrophy, but while see over here you can see properly the dystrophy which has happened. Okay, now you can see certain skin lesions. So you can see this lacy pattern over here. See, okay, can you see the lacy pattern here? Right, so this is what you have to see. Okay, so first thing is a skin involvement, skin hyperpigmentation. That could be a lacy reticular pattern. Next is nail involvement, that is nail dystrophy. So they'll start with grooves. Okay, so vertical grooves, and eventually the nail only might go off. So the nail dystrophy is there. Third, there is mucosal leukoplakia. You should remember mucosal leukoplakia. Fourth is the ocular thing. So ocular, main thing is these children will have epiphora. There is a persistent tearing in the eyes. Okay, they'll have epiphora. Other than that, what are the other ocular features? They could have conjunctivitis, they can have blepharitis, they can have strabismus, they can have optic atrophy. Okay, so other features which are involved, other genitourinary involvement, they can have horseshoe kidney. Okay, they can have hypospadias, they can have undescended testes, they can have phimosis, right? So next, coming to the hepatic involvement, this is a very small portion of these children can have hepatic involvement. There can be hepatomegaly, there can be hepatic fibrosis. Likewise, the pulmonary involvement will also have pulmonary fibrosis. So this is it. Okay, so now coming to the diagnosis. So in the diagnosis, what one second, let me see here. So what are the tests you do for the diagnosis? So one thing is you get a CBC, you will see pancytopenia. Okay, and another thing is when you get when you search for the telomeres in these patients, they have short telomeres. Okay, they have short telomeres. Okay, that you should keep in mind. Okay, and this is more of a clinical diagnosis. So now with one, you can do genetic gene sequencing, genetic testing, you can check for short telomeres, but very important is there is aplastic anemia, and the clinical feature is clear very clear that this should be dyskeratosis congenita. Okay, so there are few syndromes. I don't know if it is very important for you all. I'll just write it down here. There are few syndromes which have a overlapping feature with dyskeratosis congenita. Okay, so for example, overlapping syndromes, I'll just write it down, just that you all will know about it. Don't break your head. Okay, break your head into this. So one, there is Hoyeral Raydarson syndrome. Hoyeral-Raydarson syndrome. Over here also the gene which is affected is the DKC1 gene. Okay, so DKC1 gene. So these children will have aplastic anemia. So there is aplastic anemia, they'll have microcephaly, there will be growth retardation, and very important thing is they will have cerebellar hypoplasia. So I'm just telling, don't break your head with this. I'm just telling I mean, you should know about it. Just know about it. You don't go to the details of this. Okay, cerebellar hypoplasia. Okay, so they have aplastic anemia as well. Hmm? Next, another thing is called the Revesz syndrome. Revesz syndrome. Okay, so these children will have cerebellar hyperplasia, hypoplastic nails, they'll have aplastic anemia. Okay, because these features overlap, that is why it is said. Okay, so Revesz syndrome. And another thing for R, these children also have exudative retinopathy. Okay, they have retinopathy, reverse syndrome. Okay. Thirdly, there's another syndrome that is called the Coates plus syndrome. So Coates plus syndrome is what? Over here, what happens is there is retinal telangiectasias. Okay, there will be leukodystrophy. Generally, the brain involvement is there. Okay, so there is a gastrointestinal bleeding, portal hypertension is there. So just keep in mind these certain there are diseases which have a similar feature like dyskeratosis congenita. So when the questions come, you will be knowing, okay, what should I think about? All these three conditions will have aplastic anemia. Okay, they have features similar to this dyskeratosis congenita because they have ectodermal involvements. They have nail dystrophy. Okay, so Revesz syndrome has nail dystrophy. Okay, like that. So it is just an overlapping syndrome. Just know the names. Don't break your head too much with this. Okay. Oh, I can't. Okay, fine. What is the treatment? Okay, I change over here. Treatment. Okay, so what is the treatment? So the treatment is similar to Fanconi anemia. So tell me what was the treatment I told you? What was one drug which was told there? Which was one drug which was told in the Fanconi anemia? So I had told you in Fanconi anemia we use androgens, right? Androgen. So androgens help in improving the counts, right? It helps in improving the counts. So I was telling. So in Fanconi anemia, I said oxymethylone is the drug which is used, right? So androgens are used here. Okay, they can give with or without steroids. This is one form. Very good, Ganesh. Androgens are used. Very good. Next one is androgens. Next here you can use cytokine therapy with granulocyte colony stimulating factor. Okay, or granulocyte colony stimulating factor with erythropoietin. Erythropoietin can be used. Okay. Next best treatment is the very best treatment is the hematopoietic stem cell transplant. So this is a good treatment, but the problem with this is even if you do give hematopoietic stem cell transplant, the fibrosis part will still happen. Fibrosis will still happen. Okay, but the aplastic part will improve. Okay, even though you do the hematopoietic stem cell transplant, the pulmonary fibrosis, the hepatic fibrosis will still happen. So this you should know. So androgen with or without steroids, then cytokine therapy with the granulocyte colony stimulating factor, or you can give granulocyte colony stimulating factor with erythropoietin, or you can give plain granulocyte colony stimulating factor. Okay, so these were the drugs. So coming to the complications. So what are the complications? So again, over here, these children have a chance of developing cancer. So over here, they have an increased risk of, similar to Fanconi anemia, there is an increased risk of squamous cell carcinoma. Okay. Also, myelodysplastic syndrome. So over here, so what did we see? Fanconi anemia, they are more prone to develop squamous cell carcinoma. Next we saw Schwartzman diamond syndrome, more chance of developing myelodysplastic syndrome. While dyskeratosis congenita, they have squamous cell carcinoma as well as myelodysplastic syndrome. Okay, this you should know. Next, what is the prognosis? Okay, the mean age of death is 30 years. Okay, median life survival is 30 years. So this much you should know. And another thing I forgot to tell in Schwartzman diamond syndrome is the pancreatic insufficiency improves in 50% of the patients by its own. Okay. So here in the prognosis part, 50% of the patients, the pancreatic insufficiency improves with once you start with the replacement therapy and all that, it improves. Okay, so now we'll talk about dyskeratosis congenita. We'll have a fast quick revision. So this is another inherited form of aplastic anemia. So you should remember this has mucocutaneous abnormalities with bone marrow failure. Okay. Okay. So the triad which you should remember is there is skin pigmentation, there is nail dystrophy, and there is mucosal leukoplakia. Okay, the genes which are affected here is the genes which code for the telomerase complex. So the inheritance is three types: the X-linked recessive, autosomal dominant, autosomal recessive. For X-linked recessive, the gene is the DKC1 gene. Okay. Next, what are the manifestations? So they'll have skin pigmentation. I said there is lacy reticulation of the skin, right? So that we see. Next, we see nail dystrophy. Okay, so it starts with vertical grooves and then it becomes, then eventually the entire nail might be lost. Thirdly, mucosal leukoplakia. Okay, the whitish patch on the tongue and the oral cavity, what you see. The first thing to appear is the skin pigmentation and nail dystrophy, and eventually there will be mucosal leukoplakia, mucosal leukoplakia which happens. Leukoplakia. Next, there is persistent ocular tearing, that is epiphora, eye abnormalities, conjunctivitis, strabismus, cataracts, blepharitis, and optic atrophy is seen. Skeletal, what are the skeletal features, abnormalities we see? There is osteoporosis, there is mandibular hypoplasia, avascular necrosis. And the genitourinary abnormalities, similar to Fanconi anemia, there is horseshoe kidney, there is hypospadias, there is phimosis, there is undescended testis. Remember this. And very important feature when it comes to other organs are the fibrosis. Okay, there is pulmonary fibrosis, hepatic fibrosis, there is gastrointestinal bleed in these children. Okay, so these are the pictures which represent dyskeratosis congenita. Okay, the first is mucosal leukoplakia. There is whitish plaque kind of a thing over the tongue, you can see here. And in the nail, you can see there is dystrophy, there is wasting of the nail. Okay, there is change in the shape of the nail. Thirdly, you can see the hypopigmentation. There is this lacy pattern which you can see in the skin, right? Then there is same pictures. Okay, so treatment involves androgens. Okay, granulocyte colony stimulating factor and hematopoietic stem cell transplant. Okay, so now I will ask you all questions. Now today's topic and yesterday's topic, I will just ask you all questions. I want to know how much you all know. I know Ganesh and Aparna both are here, so you all are going to answer me. Okay, fine. So now tell me, what is the defect in Fanconi anemia? In Fanconi anemia, what is the defect? Why does these children have Fanconi anemia? What is the problem in these children? Pathology. Yes, FANC gene is affected. So what happens? FANC gene is affected. What happens in the, because this gene is affected, what happens? There is chromosomal breakage, right? Chromosomal breakage happening because of the oxidative stress. All right, oxidative stress. So basically this gene encodes for proteins which prevent oxidative stress, right? So that is why chromosomal breakage happens. Okay, now tell me, what are the drugs, what are the agents used in chromosomal breakage test? There is a chromosomal breakage test I spoke about. So what are the two agents which are used? So correct, Ganesh. Now tell me, what are the agents which are used in the chromosomal breakage test to induce the breakage of the chromosome? Yes, correct. DNA is not synthesized. Correct, Ganesh. Correct. So now tell me, chromosomal breakage test. What is? Yes, very good. Very good, Aparna. DNA is not synthesized. Very good. So chromosomal breakage test, we give mitomycin C and one more. Mitomycin C and one more drug. I, I said DEB. So what is DEB? Diepoxybutane. Remember, diepoxybutane. Fine. So these two are the agents. So either one of them is added to the lymphocyte culture of the Fanconi anemia patient, and then when you compare with the control, you see that there is chromosomal breakage. So very good, both of you have answered mitomycin C. Another is the diepoxybutane. Very good. Next, yeah, what is the inheritance of Fanconi anemia? What is the inheritance? What is the inheritance? Yes, very good. It is a autosomal recessive inheritance. Very good. Okay. Next, tell me, what are the skeletal abnormalities? Skeletal abnormalities. Yeah, both good. Parna and Ganesh both have said it's autosomal recessive. What is the skeletal abnormality? What you see here? Very important abnormality. What do you see? Short stature, yes. With a bone, associated with one bone. Yes, absent radius, absent thumb. Very good. Or abnormalities in the radius, abnormal thumb. Very good. Very good. Okay. So what skin manifestations can these? Microcephaly, yes. Very good. Microcephaly. Very good. Microcephaly. Okay. Another thing. Okay, fine. The treatment, you all know, you've already discussed. You've already, yeah, microphthalmia is there. Very good. Very good. Very good. Low set ears, I've not said yesterday. Okay, low set ears also. Avascular necrosis. Did I say avascular necrosis yesterday? Cafe au lait spots. Correct. Skin is there is cafe au lait spots. Very good. Au lait spot. Okay. So these are the things. So you all know. I'm very happy. You all know Fanconi anemia. In the management, in the treatment part, what are the drugs which are used? Yes, skin pigmentation is there, Aparna. Okay. So in the treatment part, what is there? Avascular necrosis is dyskeratosis congenita. Okay. Hematopoietic stem cell transplant. Next, what is the drug? Androgens which are used. Androgen, that is oxymetholone. Fine? Remember. Okay. Now first I'll ask you a question about today's topics. Today's we'll discuss. Now tell me, what is the inheritance of dyskeratosis congenita? Congenita. So we'll make a and Schwartzman diamond syndrome. Okay, so we'll do this so that we What is the inheritance? Yes. X-linked recessive, then X-linked recessive. There are three inheritances here. So X-linked recessive, autosomal dominant, autosomal recessive. So in Schwartzman-Diamond syndrome, what is the inheritance? Yes, both are right. In Schwartzman-Diamond, it is autosomal recessive. Yes, with chromosome 7. Very good. Okay. So now in dyskeratosis congenita, the genes which are affected encode for what? What is the abnormality? The genes, the abnormality in the gene is what? I mean, I'm not talking about, I don't want the name of the gene. These genes encode for what? Dyskeratosis congenita. So these encode for the telomere complex. Remember I told you telomere complex. Telomeres. Telomere complex. Okay. Telomere complex. So dyskeratosis congenita, telomere complex. So based on because of that, there is death of the cells faster. Okay, telomerase is required for the prolongation of life of the chromosome, right? So the telomere complex is affected in these children. Okay. Okay. In case of presentation, now tell me the presentation for dyskeratosis congenita. What are the three main things you need to know? Tell me what are the three main things you need to know. Tell me what is the triad I told about in dyskeratosis congenita. So you should know the one is skin, nail, and the oral mucosa, right? There is skin pigmentation, there is nail dystrophy. Very good, very good, very good, very good. Mucosal leukoplakia, nail dystrophy, very good. Then skin pigmentation, very important. Skin, okay, there is a lacy pattern. Skin, very good. And ocular changes, very good. Fine. Now tell me what is the presentation, main presentation in these children with Schwartzman-Diamond syndrome? Very good. Both of you all are right. Now tell me what is the presentation in Schwartzman-Diamond syndrome? Aplastic anemia with this particular thing, that means it is Schwartzman-Diamond syndrome. What is it? Yes, very good. Pancreatic insufficiency. Very good. So, aplastic anemia with pancreatic insufficiency, both of you are very good. Short stature. Short stature, yes, but very important you keep in mind is pancreatic insufficiency. Okay, very good. Can you all tell me a mitochondrial disease disorder with pancreatic insufficiency? You all know a name, a very important name. Mitochondrial disorder. Yes, very good, Aparna. There is fat malabsorption. Now tell me a mitochondrial disorder with pancreatic insufficiency. Name a mitochondrial disorder with pancreatic insufficiency. That could be a differential. That is why. But there is no aplastic anemia. Tell me a mitochondrial disorder. Mitochondrial disorder with pancreatic insufficiency. Gamma globinuria. I'm talking about This one, mitochondrial. So it is Pearson syndrome, Pearson disease, Pearson disease. See, P for pancreas. Remember, that is a mitochondrial disorder that will show pancreatic insufficiency. Okay, so very good. Fine. Yeah, I think this much is enough. Yeah, this much should be enough. Okay, another thing about Schwartzman Diamond syndrome, in the investigations, when you get a CT and ultrasound, you will see that there is fat replacement of the pancreatic tissue. Okay, so very good. So you all are remembering. So like this only you all should remember. So at the end of the class, you'll have, I hope you'll have made a short notes. Only what's important should be there in your notes. Okay, not everything what I say also. Now see, now I made the small notes, right? So like that your notes should be, so that it will be easier for you to revise. Okay, so that you should do short notes. So when you turn, you should be able to finish your topics fast. Okay, so now what did I say? Fanconi anemia, there will be absent, there will be cafe au lait spots, there will be short stature, then there will be absent thumb or radii. So that is Fanconi anemia. Schwartzman Diamond syndrome, aplastic anemia, short stature, and pancreatic insufficiency. Dyskeratosis congenita, aplastic anemia with ectodermal features like the nail dystrophy, skin manifestation, and mucosal and ocular involvement. So there are three have different presentations. Okay, so no confusing at all. Fanconi anemia and Schwartzman Diamond syndrome, it is autosomal recessive inheritance only. Dyskeratosis congenita, there is X-linked recessive, autosomal dominant, and autosomal recessive. In Fanconi anemia, there is breakage of chromosomes, while in dyskeratosis congenita, there is telomerase activity is decreased. While in Schwartzman Diamond syndrome, the ribosome biogenesis is not happening. That's it. Then we'll know. And the chromosome, which is gene which is affected in Schwartzman Diamond is SBDS. Only the B is not there. That means B is there. Schwartzman Diamond syndrome. So you should add B. Okay. So add B. So you think it is a bad gene. So B, SBDS. Fine. So I think this is done for today. Very good. Okay. So now tomorrow I am not having a YouTube class. On Monday I'll be speaking about Diamond-Blackfan syndrome. Okay, so Diamond-Blackfan syndrome, basically in aplastic anemia, you have to see a lot of, you have to see pancytopenia. Okay, in Diamond-Blackfan syndrome, what happens? There is only red cell aplasia. Okay, so that is one. Yes, correct, Aparna. Oral. So in Fanconi anemia, the cancer is the squamous cell carcinoma. Okay, squamous cell carcinoma. First, the most important squamous cell carcinoma in Fanconi anemia is the head, neck, and the upper esophagus. That is followed by then the this thing. What is it? The cervical cancer and all that. So one more thing you all should know is in Fanconi anemia, there is high predisposition to cancer because of the human papilloma virus. I told you yesterday, there is human papilloma virus. Because of that, these children have high chance of developing cancer. And another in the treatment part is, once you diagnose Fanconi anemia, these children should be vaccinated with human papilloma virus vaccines, so that to prevent the chance of these children developing into these solid tumors. Okay, fine. So we'll be talking about on Monday Blackfan Diamond syndrome. And along with that, I will speak on some of the acquired causes of pancytopenia. Okay, so this is about Monday's class, and tomorrow at 10 a.m. in the special class, I'll have a short class on Enoch-Schonlein purpura, HSP. So you all have asked me to have an MCQ in the beginning, right? So I'll have a few MCQs, maybe like 5 to 6 MCQs on rheumatological disorders, so that it will help you to remember also. So I will start with a questionnaire MCQ, and after the questions are discussed, then I will do a small discussion on Enoch-Schonlein purpura. That is 10 a.m. tomorrow and in the special class. Okay, that is it. And then from Monday I will do a class on vasculitis, so Takayasu's arteritis. So all these short topics I'll discuss. Once only I will not club. I realize that clubbing together becomes too much. Okay, so one short class, maybe for half an hour, 45 minutes, we'll discuss like that. Okay, so Monday it is black and diamond syndrome with other acquired causes of pancytopenia, and tomorrow morning at 10 o'clock I'm having a special class on Henoch-Schwann-Lane purpura. Okay, so as I always say, study well, daily study, do not break your routine, then be away from social media. Thirdly, if you have friends or a study partner, discuss with them for at least half an hour. Okay, so that will help you to remember better. And sleep early, wake up early and study. Yeah. Hi, Jay sir. Okay, another thing is, if you're subscribing to the subscription, use my code Shilpa10, you get a 10% discount. Okay, and it will help me to remain in this platform for a longer time. Okay, so good luck, study well, stay healthy, stay safe. Okay, good luck, bye.